So you may have heard of multiple myeloma, but what exactly is it? Well, multiple myeloma is a malignant disease of plasma cells within the bone marrow. It is the second most common hematological cancer and the most common and deadly of the plasma cell neoplasms. Within the bone marrow, hematopoietic stem cells normally differentiate into B cells and eventually into plasma cells. Approximately 5% of cells in the bone marrow are plasma cells. These plasma cells secrete a mixture of antibodies in order to fight infections. So patients suffering from multiple myeloma experience significant amounts of proliferation of hematopoietic stem cells, which consequently results in a lot of extra plasma cells. The percentage of multiple myeloma affected plasma cells within the bone marrow sits at about 10%. These malignant cells secrete light chains and abnormal antibodies, which cause a number of problems for the individual, such as immunosuppression, lytic bone lesions, renal insufficiency, and anemia. A state of immunosuppression occurs in multiple myeloma patients due to malignant plasma cells secreting non-functional antibodies, which then interact with the performance of functional plasma cells. This interaction exposes the patient to foreign bodies, which can consequently lead to infections. So generally, multiple myeloma tends to affect older people. Besides the elderly though, multiple myeloma does have a predisposition to affect men over women. Currently, there are no known definitive risk factors for the disease besides gender and age. These malignant cancer cells can lead to lytic lesions due to the secretion of cytokines. Osteoclast activity is amplified due to the secretion of these cytokines, such as IL-3, IL-6, DKK1, and MIP-1. This amplification of osteoclast activity leads to the increase of bone breakdown while simultaneous silencing of osteoblastic activity, which then further inhibits bone formation. This leads to a net breakdown of bone, resulting in lytic lesions, fractures, and hypercalcemia. Renal insufficiency is caused by the abnormal secretions of the aforementioned light chains by these malignant plasma cells. The proteins are small enough to enter the kidney glomerulus and have both a toxic effect on the tubules as well as a buildup of amyloidosis, which interferes with the fluid and electrolyte balance within the kidneys, causing renal obstruction and eventually chronic renal failure. Finally, anemia within multiple myeloma has 3 different causes. Firstly, within the bone marrow, there is a shift in hematopoietic stem cells, leading to a decrease in the total percentage of erythrocytes made. This is done due to a shift in hematopoietic stem cells from myeloid to lymphoid, which further accelerates the rate of plasma cell formation. The abundance of plasma cells overpopulates the bone marrow, which further prevents erythrocyte formation. And lastly, kidney failure also decreases the formation of erythrocytes. Some investigations used for multiple myeloma include the use of blood tests to detect anemia, hypercalcemia, decreased functional immunoglobulins, and increased light chain levels. We can also use urine tests to detect the excretion of these light chains. Other investigations may include bone marrow aspirates to find the malignant plasma cells, serum and urine electrophoresis for the detection of abnormal plasma cell secretions, as well as imaging to observe lytic lesions and bone fractures. For the diagnosis of the disease, firstly, there must be greater than or equal to 10% of monoclonal plasma cells found within the bone marrow. Secondly, monoclonal antibodies must be detected within the blood or the urine. Along with these, at least one of the following must be identified within the patient: hypercalcemia, renal failure, anemia, or lytic bone lesions. There are various treatment methods for this disease, including chemotherapy, radiotherapy, blood transfusions, and stem cell transplants.